everyone. Our today's topic is atherosclerosis. You know the meaning of atherosclerosis. You have studied in myocardial infarction, and the causes is the atherosclerosis. Actually, it is due to the dysregulation of cholesterol metabolism. When the sum of cholesterol synthesized and the cholesterol obtained from the diet exceeds the amount required for the synthesis of plasma membrane, bile salts, steroid, etc., and there will be an accumulation of cholesterol, that is called the plaques, which can obstruct the blood vessels, and the condition is called the atherosclerosis. So the atherosclerosis is due to the dysregulation of the cholesterol metabolism. Now we can see various stages of formation of atheromatous plaques within the vessels. This is the normal vessel, then it is slowly increasing, the plaques are forming, and finally it is converted into a thrombi which occludes the lumen of the vessel. So atherosclerosis, the word meaning of sclerosis is hardening in the Greek, and the coronary artery obstruction and the myocardial infarctions are the main causes for the death in the world. The incidence of mortality in India is about 20%. It is estimated that by 2020 it may rise up to 33%. So the incidence is increasing by year. Now, what is the pathology or the changes occurring in the atherosclerosis? Focal plaques within the intima containing cholesterol and cholesterol esters are seen, which affects mainly the large and medium-sized arteries. So it is usually affecting large and medium-sized arteries. Then it causes coronary artery disease. Then it is due to hypercholesterolemia, that is high cholesterol level. Elevated LDL and triglyceride are associated with increased risk of atherosclerosis. Serum HDL level has got an inverse relationship to the risk. That is, if it is less, there will be increased chance for the atherosclerosis. If LDL is increased, triglycerides are increased, there is an increased risk. But HDL, the level, if it is decreasing, that is more risk to the formation of atherosclerosis. So in this picture also you can see the normal artery, then the mild atheromatous plaques within the vessels, and then severe atherosclerosis, which is occluding the lumen of the artery. Now, how the atherosclerosis develops, various stages of development, that is very important. First stage is the formation of foam cells. Increased cholesterol for long period will favors its deposit in the subintimal region of the arteries. So slowly developing disease, when the cholesterol level increases for long time, it will deposit in the subintimal region of the arteries. The major vessels affected are aorta, coronary arteries, and the cerebral arteries. The LDL, which is mainly oxidized LDL, are deposited in the arterial walls. So when there is increased cholesterol, then more LDL cholesterol will be formed, and when the LDL is oxidized, that is oxidized LDL is the one which is depositing in the arterial walls. LDL is usually catabolized by the ApoB LDL receptor pathway. You have studied that, but a few portion is catabolized by the uptake by the macrophages. So scavenger receptor system, where the macrophages will take up the LDL, that is also taking place. Free radical induced oxidative damage will increase the degradation by the macrophages. So whenever there is free radical production, that will induce oxidative damage, and that will increase the LDL degradation by the macrophages. Macrophages then become overloaded with the cholesterol, and it is known as the foam cells. So in the cholesterol, there is overloading of the cholesterol. In the macrophages, there is overloaded cholesterol, which finally forms the foam cells. So that cells are hallmark of the atherosclerosis. Foam cells form the hallmark of the atherosclerotic plaques. So within the intima, there will be foam cell formation. So here you can see the monocyte recruitment, which is producing the macrophages, and then it is for LDL is taken up, and the LDL is usually oxidized LDL, which is finally forming in the macrophages. It is forming the foam cells. So these are the foam cell which is seen in the subintima of the arteries. Stage 2, there is progression of atherosclerosis. What happens in this stage? Smooth muscle cell which contains the lipid droplets are seen in the lesion. So there smooth muscle cells are seen, which is filled with the lipid droplets are seen in the second stage. In the third stage, there is fibrous proliferation. That is, macrophages and platelets liberates various growth factors, and then lipoproteins, glycosaminoglycans and collagens are accumulated, and hence there is an inflammatory process occurring in the atherosclerosis. So in the fibrous proliferation stage, macrophages and platelets are liberating various growth factors, and then lipoproteins, glycosaminoglycans, collagen, which are the extracellular matrix substance, are accumulating. So this together forms an inflammatory process in the vessels. This chronic inflammation releases plasma high sensitivity C reactive proteins. So there will be an increased level of C reactive proteins in the blood. That is mainly due to this inflammatory process occurring in the formation of atherosclerosis. That is, chronic inflammation usually releases plasma high sensitivity C reactive protein, HSCRP. So usually in the atherosclerotic patients, we can see high sensitivity C reactive proteins levels may be increased in the blood. So another picture where you can see the formation of plaques. So first monocyte recruitment, then macrophages are overloaded with the lipid droplets and produces the foam cells, and smooth muscles are also laid with the lipid droplets, and there is lipid core in the subintima which is protruding to the lumen, and there will be fibrous proliferation and the deposition of collagen, glycosaminoglycan, etc. in the region, which is also protruding to the lumen. So again, the tissue factors, growth factors are released. Platelet aggregation occurs in this area, and then the whole of this thing forms a thrombus and encroaching to the lumen of the artery. Now the stage 4 is the advancing fibrous plaque formation. Narrowing of the vessel wall occurs due to the proliferative changes, that is thrombus formation. So thrombus formation occurs and that will narrow the lumen. Blood flow through the narrow lumens leads to the formation of clot. So when there is turbulence of blood through a narrow lumen, there will be a chance of formation of a clot. So clot formation also occurs in the stage 4. So these 4 stages are the stages of formation of a atherosclerosis. So you have to study all these stages, and first oxidized LDL, there is some intimal damage, epithelial damage, endothelial damage will be there in the vessels by some oxidative free radicals, and then what happens is when the cholesterol level is very high, the LDL is taken to the subintimal region where it is oxidized LDL get deposited, and the monocyte recruit the macrophages which is filled with this oxidized LDL, and then it is catabolized, and then it is forming foam cells. These foam cells, and after that there is release of growth factors and all. Finally smooth muscles are also laden, and then the extracellular matrix are laden and forming the thrombus which narrows the lumen, and finally when there is a turbulence of blood flow, there will be formation of clot also. So these are the various stages of formation of atherosclerosis. Now, what is myocardial infarction? We have studied it. The major vessel supplying the myocardium is occluded by the clot. Thrombosis of coronary arteries produces ischemia due to the loss of oxygen supply. So, the myocardium heart is supplied by the coronary arteries. When this coronary artery is occluded by the clot, what happens is there is ischemia, loss of blood supply. So this loss of blood supply produces loss of oxygen supply. Due to ischemia, there is anaerobic glycolysis, which will decrease the ATP production and increase the NADH. So the accumulation of lactic acid occurs. Pyruvates, more of lactic acid will be formed. Then there is decreased pH, that is acidosis of the cardiac muscle cells. This results in the death of cardiomyocytes at this area. So that is what happening in the myocardial infarction. Due to ischemia, all these changes occurs. That is anaerobic glycolysis, decrease in ATP, increase in NADH, accumulation of lactic acid, which will lead on to acidosis, and the myocardial cells are dying, and that is called the myocardial infarction. The diagnosis of myocardial infarction is mainly by the clinical history. Then you can take ECG and get the changes, and then you can send the blood for the cardiac biomarker estimation, that is troponins and CKMB. Then after diagnosing, you can immediately give some medicine, that is administration of tissue plasminogen activator may reduce the size of the infarct. So that is about the myocardial infarction, which can be produced by the atherosclerosis and the immediate management. So in the atherosclerosis pathogenesis, what is happening in a nutshell, we can see there is chronic inflammatory response of the vascular wall to the endothelial injury or dysfunction. Due to endothelial injury or dysfunction, there is chronic inflammatory process of the vascular wall. Elevated plasma LDL level causing deposited of the LDL in the subendothelium of the blood vessel. So when there is increased cholesterol for a long time, there will be elevation of plasma LDL, which will deposit in the subendothelium of the blood vessels. Then it get oxidation of transmigrated LDL. LDL in the which is deposited will get oxidized. Oxidized LDL is more dangerous. So activation of the endothelial cells occurs, and there will be recruitment of monocytes and then macrophages, which ingest the oxidized LDL through a scavenger receptor. So when there is recruitment of monocytes and macrophages which ingest, it will take up the oxidized LDL through the scavenger receptors. This will form the form cells or fatty streaks. Then there is proliferation of the smooth muscle cells, a deposition of the extracellular matrix by the growth factors. So various stages you can see, lipid accumulation leading to the atheromatous plaque formation. Then there is platelet aggregation, then the plaque again formation forming a thrombus, and the thrombal expansion and full vessel occlusion. Full vessel is occluded here. So this is the coronary artery shown here. This is another picture where you can see various stages, formation of form cells, then fatty streaks, then intermediate lesions, then atheroma plaques are extending, and then there is fibrous plaque formation, and then finally the complicated lesion which will rupture to the lumen. Again, one more picture where the cross section shows the smooth muscle. This is the normal artery, but this is the one which is having atherosclerosis. And here you can see the intima endothelial vessel wall is damaged, and then smooth muscles are there. Macrophages transform into foam cells which is containing fat, and then lipids, calcium, and the cellular matrix are deposited, and there is a fibrous cap which is the thrombus. Here also we can see the normal. There is a tear in the endothelium, then small, there is fatty streaks developing, and finally there is an occlusion of the artery. Now we have to know something about the cause, study something about the cause. So classification of plasma cholesterol concentration in various levels. So less than 200 is the desirable value of cholesterol, and the 200 to 239 milligram per deciliter is the borderline, and above 240 is the high risk case. So we have to maintain the blood cholesterol below 180 if the person is a normal person. Then if it is between 200 and 239, it is a borderline risk. Above 240, high risk patients. So we have studied in the last sessions, that is lipid profile and dyslipidemia. What is plasma lipid profile? That is, we are estimating the lipid profile in the fasting state, 12 hour of fasting. We are estimating total cholesterol, HDL cholesterol, LDL, triglycerides, ApoB level, ApoA1 level, and the lipoprotein A levels. So the indications also: suspected cerebrovascular disease and cardiovascular disease and peripheral vascular disease. All patients at least once in 6 months. Thyroid, liver and renal disease where the lipid metabolism may be affected, and as a routine checkup in all persons above 40 years. These are the main indications for estimating lipid profile. So all persons above 40 has to do once their lipid profile study. Coronary artery disease risk and the lipid parameters. What are the risk factors and how can you assess the risk? So when the total cholesterol is less than 200 and HDL is more than 660 milligram and the triglyceride is less than 150, there is low risk. It's always normal, considered as the normal. But if the total cholesterol is between 200 and 240 milligram per deciliter and the HDL is only between 35 and 60 and the triglyceride is between 200 and 400, it is a borderline risk. These patients are having a borderline risk. And high risk patients will be having more than 240 milligram per deciliter cholesterol, less than 35 milligram per deciliter HDL cholesterol, and more than 400 milligram per deciliter triglycerides. So these patients are of high risk patients. So they can develop coronary artery disease or cerebrovascular strokes. So they have to be treated actively. Now we'll pass on to the various risk factors of atherosclerosis. So there are so many risk factors. Some are can be some due to intervention can be we can reduce the risk. When you intervene the risk factors, you can reduce the risk. So that type of risk factors are this. So modifiable risk factors. They are called the modifiable risk factors where the interventions prove to lower the coronary artery disease risk. So when you intervene all these things and making them normal, there may be a lowering of the incidence of coronary artery disease. So risk factors, that is modifiable risk factors where the intervention proved to lower the coronary artery disease. First is cigarette smoking. Cigarette smoking is very important risk factors. That is, if it is 10 cigarette smokes per day, it is highly a risk factor. That is, 10 cigarette smokes per day increase the risk by 3 times due to decreased HDL and that accumulating carbon monoxide that may cause endothelial injury. So when the patient risk of cigarette smoking depends upon the number of the cigarette smokes per day and how long it used to smoke. So depending upon that, the risk also increase. So 10 cigarettes per day increase the risk 3 times for the patients, and that is due to decrease, that will produce decrease in HDL, and there will be accumulation of carbon monoxide that may cause endothelial injury. Then high cholesterol, of course, we know what is the reason. High LDL is also a high risk. Low HDL, that is if the HDL level is decreased less than 35, it is high risk. Then high fat and cholesterol diet. Then left ventricular hypertrophy, that is a hypertrophy, or the cells get hypertrophied in the left ventricle, so the ventricle cannot contract properly. That will again lead on to atherosclerosis. And thrombogenic factors, any other thrombogenic factors is there. These are all the factors, modifiable risk factors. If you stop smoking, and if you control your cholesterol level, if you control your LDL level and increases the HDL level, and if you cut short the cholesterol in the diet and treat for the left ventricular hypertrophy and all, you can reduce the risk of coronary artery disease. Then there are modifiable risk factors where the interventions are likely to lower. There is a chance to lower the risk factors, not fully, and can likely to lower the coronary artery disease risk. That is lipoprotein A level, diabetes mellitus. If you control to some extent, you can reduce the risk. Hypertension, physical inactivity, obesity and stress, then high triglycerides, high homocysteine level, and increased hs-CRP level, high sensitivity C-reactive protein level. So when you control all these factors, there is likely chance for reducing the coronary artery disease. So these are again modifiable risk factors. Lipoproteins are usually more dangerous than diabetes. Usually there is dyslipidemia, which may later on produces atherosclerosis. Majority of the fatality in diabetes is due to the atherosclerosis, myocardial infarction. Then hypertension, of course, will lead on to the atherosclerosis. Then physical inactivity. When you are not taking exercise, sedentary life, then obesity and stress. Stress also leads to the development of atherosclerosis. Then triglyceride level, high homocysteine level, and increased hs-CRP level. Then there are non-modifiable risk factors. So the risk factors we can classify into modifiable risk factors and the non-modifiable risk factors. Modifiable, again, which is likely to lower the risk, or it can lower the risk, like that it can again classified into two. So the non-modifiable risk factors are age. We can't modify the age, isn't it? When you are getting old, there is more chance for development of the atherosclerosis, because elasticity of the vessel may be lost, and the rigid vessel, and then subendothelial injury may be more due to wear and tear, and so there may be more chances for developing atherosclerosis that we can't prevent. Then male gender, usually male are more prone to develop atherosclerosis than female, and the female has got equal risk after menopause. So there may be some protection by the female hormones and during the fertility period, and after that it is maybe the male hormones are more atherogenic. Then family history of any coronary artery disease. If it is familial hypercholesterolemia occurs in some families, they may be having more risk, and we can't modify that risk. So what are the things we have to note? Total cholesterol should be less than 200, LDL cholesterol less than 100, and non-HDL cholesterol less than 130. Non-HDL means except HDL, all others, LDL, VLDL and IDL together, it should be less than 130, has no risk provided there is no other risk factors. So in a normal person, the cholesterol level should be below 200, LDL cholesterol less than 100, and the non-HDL cholesterol less than 130 milligram per deciliter, having usually have no risk. HDL cholesterol should be above 40 milligram per deciliter in male and above 50 milligram per deciliter in female. So this should be kept always in the body. So cholesterol should be less than 200, LDL should be less than 100, non-HDL less than 130, HDL cholesterol should be more than 40 in male and 50 milligram per deciliter in female. Now we'll pass on to the risk factors one by one. Major risk factor is the cholesterol level. So increased level is associated with an increase of death from the coronary artery disease. 10% lowering of the cholesterol may reduce mortality by the 13%. So it is very important. If you reduce the cholesterol level 10%, the mortality reduces by 13%. Normal level of course is 150 to 200 milligram per deciliter. If the risk factors are present, suppose the patient is having hypertension, diabetes, etc., which are the other risk factors, preferably less than 180 milligram per deciliter should be the cholesterol level, and more than 220 milligram will have a moderate risk, and above 240 milligram usually needs active treatment. So if the patient is having some other risk factors like diabetes, hypertension, obesity, etc., then the cholesterol level should be below 180. We should keep the blood cholesterol level less than 180. If they are having above 220, then that is moderate risk, and if it is above 240, he is having high risk and he should be treated. Females have low cholesterol level with the protection of coronary artery disease. At post menopausal period, the level will rise. Second risk factor is LDL cholesterol. In 1988, National Cholesterol Education Program (NSEP) found out that high LDL level is as the primary risk of coronary artery disease. So, high LDL level is considered as the primary risk factor for the coronary artery disease. The desirable level is less than 130 or even 100, and the level more than 160 milligram have high risk. HDL cholesterol, it is a bad cholesterol. Then third one is the HDL cholesterol level. HDL cholesterol more than 60 is protective to the heart disease. So if the level is above 60 milligram, it is protective to the heart. HDL cholesterol is the good cholesterol. A level less than 40 milligram increases the risk of coronary artery disease. That is 1 milligram per deciliter decrease of cholesterol will increase the risk by 3%. So if the HDL cholesterol level decreases by 1%, then there is a risk of developing coronary artery disease by 3%. Then the total cholesterol is to HDL ratio, if it is more than 3.5%, it is dangerous. So the total cholesterol is to HDL ratio more than 3.5 is risk. Then LDL is to HDL ratio, if it is more than 2.5, also is dangerous. So TC by HDL above 3.5 is dangerous, and also LDL is to HDL more than 2.5 is dangerous. So these are the HDL. Then about the apolipoproteins level and their ratio. What are the apolipoproteins? ApoB represents the LDL and ApoA1 represents the HDL. So ApoB is to ApoA1 ratio is a reliable indicator. So the ratio 0.4 is very good. Ratio more than 1.4 is risky. So we have to keep the ratio less than 0.4. Then fifth one is the lipoprotein A level. It that it is inhibiting fibrinolysis. The levels more than 30 milligram per deciliter will increase the risk by 3 times. So when the level of lipoprotein A is more than 30 milligram per deciliter. Lipoprotein A, if the level is more than 30 milligram per deciliter, it will increase the risk by 3 times. It is also known as little rascal. Nicotinic acid will reduce the lipoprotein level usually, and it has got a risk at the early age, usually seen in the young adults. Then sixth one, non-HDL cholesterol value should be more than if it is more than 160 milligram per deciliter, it has got a high risk. That is non-HDL cholesterol value means all the LDL, VLDL, IDL together. If it is more than 160 milligram per deciliter, it is of high risk. Now, cigarette smoking, we have explained smoking increases oxidation of LDL and then reduces HDL and increases CRP and then enhance the platelet aggregation. So, it will be producing platelet aggregation. It also carbon monoxide will produce a subintimal injury. So many things happens in the case of cigarette smoking. So we have to reduce the smoke, or no, it has to be stopped. Then the risk also will decrease. Nicotine in the cigarette smoke will increase lipolysis, increase the acetyl coenzyme and later cholesterol synthesis, and also cause transient vasoconstriction. So nicotine of the smoke will produce all these things. It will increase the cholesterol level and also it has got a vasoconstriction effect. Then another risk factor is diabetes mellitus. 80% of mortality of diabetes mellitus is due to the coronary artery disease, and in deficiency, that is due to the deficiency of insulin, hormone sensitive lipase is activated and more of fatty acids are formed. Fatty acids are catabolized to acetyl coenzyme. Then there is increased level of acetyl coenzyme which forms the cholesterol, and HDL will decrease, LDL will increase, and triglyceride level also in the cell also increases in diabetes mellitus. So you know the what are the pathology or the feature changes occurring in the diabetes mellitus, and how hypercholesterolemia, increased LDL and decreased HDL, which are seen in the diabetes mellitus. Glycation and oxidation of LDL delays the catabolism of LDL and promote the uptake by the macrophage. That we have explained already. Oxidized LDL is taken up by the macrophages, that is scavenger receptors, and then catabolized in the macrophages. Glycation of ApoA1 decreases the ability to stimulate the LCAT and esterification. So what happens? Efflux of cholesterol from the cell is decreased. So there will be decreased efflux of cholesterol from the periphery to the liver for the conversion of cholesterol to bile acid and excretion. So that naturally there will be increased cholesterol in the body. So usually in the diabetes there is a chance for the glycation of ApoA1, which will decrease the ability to ApoA1 to stimulate the LCAT, that is for the reverse cholesterol transport, then lecithin cholesterol acyl transferase enzyme, which will helps in the transport of esterification and transport of cholesterol from the periphery to the liver where it is excreted. The antioxidant effect, that is peroxidase activity of HDL, is also decreased in diabetes. Now we'll pass on to the hypertension. What is the role? That is systemic BP more than 160 millimeters of mercury will increase the risk, and an increase in 10 millimeters of BP will reduce the expectancy of life by 10 years. Then an increase in 5 millimeters of mercury of diastolic BP is associated with 34% increased risk of stroke. So when there is high BP, there is increased chance, that is more than 160 there is high risk, and every 10 millimeters systolic BP increase there is a chance for decreasing the life expectancy by 10 years. An increase of 5 millimeter of diastolic BP is associated with 34% increased risk. Next is obesity and the sedentary life. Obesity can cause glucose intolerance, insulin resistance, hypertension, and dyslipidemia. So usually obese people will have a abdominal obesity, truncal obesity, or that is called the Ganpati belly or apple type of belly, which is more dangerous. There will be glucose intolerance, so everything will be affected. Insulin resistance, what happens in diabetes, just like that will happen if there is obesity. Next, serum triglycerides. Usual normal level is 50 to 150 milligram per deciliter. Level above 150 milligram is injurious to health. Then homocysteine levels, plasma level more than 15 micromoles per liter increase the risk of coronary artery disease and the stroke, usually in the young age. Then high sensitivity CRP, ultra sensitivity C-reactive protein, increases increased level is a predictor of coronary artery disease. That is, it is usually released when there is inflammatory process occurring. So it is a type of plasma protein seen in our blood, and if the level is more than 15 micromoles per liter, that shows there is some high inflammatory process going on, and sometimes it may be due to atherosclerosis. Normal is 1 milligram per liter, and more than 3 milligram per liter has got a high risk. Then long chain saturated fatty acid. Actually, the long chain saturated fatty acid has got a harmful effect on the vascular system due to the inflammatory effect on the endothelial cells. Now a new test is there, lipoprotein associated phospholipase A2, that is LPPLA2. It is also known as platelet activating factor acetyl hydrolase. Platelet activating factor acetyl hydrolase. It is an enzyme produced by the inflammatory cells, considered as a marker for plaque instability. So usually if there is plaque instability, it is released. So it is considered as a marker for plaque instability. It is actually a new test, not as a diagnostic test, only as a risk predictor. It is not used as a diagnostic test because it has to be studied a little more, and then not actually considered as a diagnostic test for the myocardial infarction or coronary artery disease, but it can predict the risk. Unlike hsCRP, the lipoprotein phospholipase A2 is not affected by disease other than cardiovascular disease. So it can be used in inflammatory process also. hsCRP and all, if there is generalized inflammation like arthritis also there in a body, then they can't use for a risk. They cannot be used as a risk factor for the coronary artery disease. But this lipoprotein associated phospholipase A2 can be used because it is not affected by disease other than the coronary vascular disease or cerebrovascular disease. So it will be elevated only in this case, not in the other inflammatory disease. So in that way, it is an important test for the predicting the risk. Now, how will you prevent the atherosclerosis? Prevention of atherosclerosis. 90% is predictable, preventable, and curable. So the atherosclerosis in general, 90% is predictable, preventable, and curable. Our aim is to reduce the total cholesterol less than 180, decrease the LDL cholesterol less than 130, and keep HDL cholesterol more than 45. At least this much should be done to prevent the atherosclerosis. So you have to maintain your cholesterol level less than 180, HDL less than 130, and LDL less than 130, and HDL more than 45. That is, if it is more than 60, it is highly protective. So for that, what all things we have to do? Reduce the dietary cholesterol. Even though dietary cholesterol has no much effect on the cholesterol level, because body is synthesizing cholesterol. but we can reduce the cholesterol to some extent by reducing the dietary cholesterol up to 200 milligram per day, like that. Then vegetable oils has to be used so that you can get polyunsaturated fatty acid, which is helping in the esterification and all. Then reduce the fat intake, eat plenty of green leafy vegetables, avoid sucrose, which will increase the triglyceride level, and avoid cigarette smoking. Do exercise regularly, that is moderate exercise. 30 minutes walk daily is good, and if you spend 2000 kilocalories per week for the exercise, it is very good. If you can't walk 1.5 kilometers per day, it is dangerous also. Then avoid trans fatty acids, which are atherogenic and should not exceed 2 to 3 grams per day. You know what is trans fatty acids? It helps in the hydrogenation of food, and it is usually used in the food industry. It has got a high shelf life. So if the amount of trans fatty acid is more, then there is more risk. It is alter the fluidity and everything. There will be increased chance for atherosclerosis. So the level should not exceed 2 to 3 grams per day. So better to avoid the junk foods which may contains the trans fatty acids. Then you can use, of course, hypolipidemic drugs which will reduce the cholesterol. Then POFA in excess is harmful, but it is in moderate quantity. These vegetable oils are good, and the omega-6 fatty acid is to omega-3 fatty acid should be in the ratio of 4:1. And the long chain fatty acids increase the cholesterol level. So the prevention in general, get regular medical checkups where you have to see whether you are having diabetes, hypertension, and high cholesterol, lipid profile has to be checked. All these things you can see. Then control your blood pressure, check your cholesterol, don't smoke, exercise regularly, maintain healthy weight to reduce the obesity, eat heart healthy diet, and manage stress. How can you manage stress? By doing meditation. So the therapeutic strategy is, first one is identify the patient at risk by routine screening of the serum cholesterol and the assessment of contributory risk factors. Contributory risk factors means diabetes, hypertension, and other familial disease, etc. Then second one is non-pharmacological therapy without any drug, that is diet modification and the lifestyle modification. Lifestyle modification by doing exercise and managing stress, etc. Then third is the pharmacological therapy, that is due to by using drugs. Then last one is intervention. If drugs cannot prevent this, then you have to do the interventions like angioplasty, coronary bypass grafting, coronary artery bypass grafting. This is the final thing which has to be done in myocardial infarction. Now we'll pass on to the hypolipidemic drugs. HNG-CoA reductase inhibitors or statins, we have mentioned in dyslipidemia. They are effective in reducing cholesterol level, reduce the incidence of coronary artery disease. Examples of statins, atorvastatin, simvastatin, fluvastatins, and so many are there. If they are effective in treating early stages of coronary vascular disease, that is called the primary prevention, and those with increased risk but no coronary vascular disease, that is primary prevention. So when there is early stages of disease, if we are treating with statins, it is called the secondary prevention, and those with increased risk but there is no cardiovascular disease, then it is called the primary prevention. So as a primary prevention and secondary prevention, we can use the statins. It will prevent the events by improving the endothelial function, modulating the inflammatory response, and maintaining the plaque stability and preventing clot formation. So these are the main thing which produces atherosclerosis, right? Improving endothelial dysfunction may be there may be inflammation, there may be plaque formation and clot formation. So all these things can be prevented by the use of statins. Indication, of course, all patients with confirmed cardiovascular disease as a prevention, patients with diabetes mellitus over 40 years, complication with retinopathy, nephropathy, microalbuminuria and hypertension, then total cholesterol above 220 and LDL above 130, TC is to HDL more than 6 ratio, a family history of early coronary vascular disease, lifestyle modification if it is not having much effect on the reduction of cholesterol level. Second type of drug is bile acid binding resins, decreases the reabsorption of bile salt from the intestine, so it will help in the excretion, that is cholestyramine and cholecystipol. Then probicol increase the LDL catabolism and prevents accumulation of LDL in the arteries. More cholesterol is converted to bile acid and cholesterol level may be decreased. Then fibrates, examples clofibrate and gemfibrozil, decrease the secretion of triacylglycerols and cholesterol containing lipoprotein VLDL by the liver. Hence decreases the triglyceride levels in the blood. Nicotinic acid inhibit lipolysis and also thereby VLDLs are decreased. It decreases cholesterol and serum lipoprotein A. Niacin is the most effective drug in increasing the HDL and lowers the TG and LDL. So it is very useful drug. Then ezetimibe selectively inhibit cholesterol absorption from the mixed cells. And aspirin is preventing thrombus formation due to its antiplatelet activity. Then vitamin E, C and beta carotene decreases oxidation of LDL due to antioxidant activity. So the expected effect of drug therapy, various drugs is shown here. Statins decrease the LDL by 35% and increases HDL by 10%, not much effect on the TG. Fibrates decrease the LDL by 15% and increases the HDL. So it will increase HDL very much, 20%. Niacin decreases the LDL by 20% and increases the HDL by 25%. So niacin has got a good role, that is it will decrease the LDL and increase the HDL. Cholestyramine decreases the LDL level and ezetimibe also decreases the LDL level. Then there are some plant derived products, containing fibers that will reduce the cholesterol. Legumes reduce cholesterol even on high fat diet. Then phytosterol have LDL lowering effect. Recommended dose is 1.6 to 3 grams per day. Onion and garlic reduces cholesterol and TG. Spices, flavanols and red wine are natural antioxidants and prevent oxidation of LDL. So the treatment, atherosclerosis, many people are able to manage coronary artery disease with lifestyle changes and medication. So usually if they know early, the risk factors are known early, then they can manage by lifestyle changes like good diet and then exercise and managing stress. They can manage the prevent the coronary artery disease. But other people with severe coronary disease may need angioplasty or surgery. So in this diagram you can see various, this the infarcted area, narrowed lumen, rotational burr is the angioplasty, the burr is introduced, balloon angioplasty and the stent, medicated stents are there. So if this is the usual method now, then if it is multiple block and all, we have to do coronary artery bypass grafting. So this about the atherosclerosis, mainly the pathogenesis, how it is developing, what are the risk factors, various type, modifiable and non-modifiable. Modifiable again, which are likely to reduce and which is reducing and which are likely to reduce. Non-modifiable risk factors, then the what are the things to be done as a treatment, how will you manage the case. Thank you all.